This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson. It's my pleasure to have with us tonight Dr. Sumner, who is Dean of Mercer Medical School. Welcome, Dr. Sumner. It's a pleasure to have you with us tonight. And you have a very responsible job, do you not?
I do.
You're looking after a lot of young people that are aspiring to be physicians.
It's really it is a challenging job, but it's they inspire you to do better, and they're young people who want to serve the state, and so they're working hard over there. We're trying to make sure they come out of that process prepared to take care of patients.
And well, let's see, the medical school, if I can recollect this, you're a graduate of Mercer, and the medical school started in Macon, and it was
the
30 years?
First class entered in 1982, graduated in 1986. So
and were you one of the first?
I was in the first class.
You were in the very first class, is that right? How did you find that? It was pretty adventurous, wasn't it?
It was. I had gone to nursing school, got a master's in nursing, and came from a family of physicians in a community that had adequate health care. Got married, moved to the adjoining county, which had no health care.
Yes.
It was the opposite of the county I'd been raised in. It was poor rural Georgia, and there was no way to recruit someone to Johnson County.
Yes.
So
county seat, Wrightsville.
Absolutely. And you know, my family had been in Washington County for years, and I had always toyed with the idea of medical school. I had taken some extra training in nursing school when I got my master's. And when Mercer opened and gave me an opportunity to come, I came to medical school and went back to Johnson and Washington counties.
Wow. So your career was you went to medical school and you had a calling, if one can use that word, to look after people in rural counties, and you did that?
Well, I came from a family that had served Washington County since before 1900, so I understood that you could practice really good medicine, and it was a lot of fun. You had an impact on your community. Your patients were people that you knew very well, so that you had intergenerational continuity. You knew their whole family, their grandparents, their aunts, uncles.
Yes, right.
You knew what they did. You knew what
and
stresses
they knew about you too.
And they knew about you. That's right.
So
there are different issues in rural health. You
Yes.
learn boundaries. You learn, but it's a lot of fun. And really good medicine is practiced in small towns across this state.
Yes.
I think we fail to recognize that there are true servants out there serving the state that practice really good medicine, and yet we don't recognize them like we should.
Now, one of the mission of Mercer Medical School is to actually provide doctors for rural health care and to keep primary care physicians in Georgia, and have they been pretty successful about that?
We have been, I think, very successful, and we're continuing to try to build on our success. We only accept Georgia applicants, so you have to be a Georgian to come to Mercer University School of Medicine. The odds of taking an out-of-state student and having them stay in the state are less, so we try to accept only Georgians. We encourage our students to go into primary care, but also to try to look for Georgia residency. We think that if you go to Mercer and get a Georgia residency, you're much more likely to stay in the state. We want you to serve an underserved population or a rural population, and we encourage that. Now, we can't control what everybody does, but we want to demonstrate to them the value of doing that, the meaningful practice that you can have, the rewarding practice you can have. And it's a different type of practice to an urban practice. We have to give them experiences in rural areas. I think we use a model of training physicians that has been around for a long time, and we typically train them in tertiary care hospitals that is needed, but they need experience in rural areas as well. So we try to combine those two.
Well, how many people, the medical school is expanding substantially, is it not? And you have, if you want, I don't know if the right word is branches, but other beachheads in other places, do you not? You're all over the
well,
state.
the original campus was here in Macon, and we opened a campus in Savannah, initially a 2-year campus that became a 4-year campus about 6 years ago. We've been in Savannah for about 20 years. And then about 4 or 5 years ago, and I don't remember the exact date, we opened a 2-year campus in Columbus.
Yes.
And Columbus has approached the school about that becoming a 4-year campus.
Yes.
So we're working with the community to try to make that happen.
So what is the enrollment altogether? How many students do you take a year?
We take 120 freshmen.
Yes.
And give or take a few.
And around that number, and it's competitive, is it not? I mean, you have a lot of applicants from everywhere. People want to go to medical school. They want to do that.
But we look for a student who has Georgia roots, is interested in our mission, and who has the personality traits that would serve that mission well.
Yes, and so I think you've been good stewards of the money that's come to the medical school. The state gives a substantial amount, does it not,
They do.
to make things work? And
We
is that
take-
a good investment? I'll ask
Well,
that question.
we
I'll throw you a
take-
softball.
Yeah, an excellent investment. We take the obligation that we have to the state very seriously, and we do everything in our power to influence those young people to look at, certainly first and foremost, service in Georgia, but we want them to serve the underserved populations. I know you know well that Georgia's on the way to being one of the states in the nation with the fewest physicians, and we also have a maldistribution of physicians. If you draw a line from Savannah to Macon to Columbus and go southeast or southwest, that area of Georgia is severely underserved. Above Macon, there are more physicians, and they're distributed primarily in urban areas.
Well, what about the impact of money, which is, that's part of the way the world has an impact. And many times students, that they are in medical school, they have to borrow huge amounts of money. They have college debts. Many people start families. They have a lot of money they owe, and they have to pay a substantial amount of interest on that. And what impact is that having on the choice that a young physician might make if they owe huge amounts of money and they've got to pay it back, and the compensation that occurs, just the system we have, if you're in a relatively poor area?
I think that if you look at the payer mix across Georgia, the payer mix in Bibb County is not dissimilar from the payer mix in Hancock County, which is one of the poorer areas of the state.
Yes.
And some of the myth of the inability to earn a living in rural Georgia is just that. It's a myth. It's not based on fact. If you look at the insured rate across that area of Georgia I just described, probably the number one employer is the state of Georgia. They work for the prisons, they work for DOT, they work for DFACS, they work for the school system, they work for corporate farms now.
Yes.
It's not as much the small-time farmer. They work for industry that has grown up across the state near interstates in some of the metropolitan areas. So it is not the barren wasteland that many people who live in cities think of it as.
Yes.
So, and then quality of life is somewhat better, in my opinion, of course, in many ways. It's a simpler life, and it's a pleasant life. And you have a great relationship with your community generally as a physician because you contribute a lot to that thing. We take student debt very seriously, though.
Yes.
And we work from the time of admission to encourage fiscal responsibility on the student. We try to decrease debt. We were very, very fortunate to receive $35 million from the state of Georgia. And President Underwood immediately committed every cent of that money to scholarships for young people from rural areas who will go back to rural areas to serve.
Wow.
And so we have structured that so that we can turn out many students every year with little to no debt.
Yes.
And if those students will go back home, we think that over the next several years we'll change the landscape in rural Georgia. I do think that rural hospitals are in trouble, but hospital care is different, and small community hospitals are important, and we need regionalized small community hospitals. But we need to work together with tertiary centers so that things that need to come to a center, like where you work, need to come there, and you need to have a relationship of some sort so that transition is easier.
Well, one of the things that it seems to me is necessary to really give the state optimal health care is just what you've talked about, a sort of a system by which people there's a cybernetic loop about quality. So we discover this happened, that happened, this happened to this patient and that didn't, and everybody's in a big sort of team trying to do the best thing they can for their patients. And some of the things that can happen is this a problem? I'll pick a county where all my ancestors are from, Wilcox County. There are a number of people that look like me, with different, shall we say, economic roles there. But the number of physicians in the county is very small, if there is one. There are about 10,000 people in the county. It's very difficult to get care. People have trouble with high blood pressure. They have strokes. They have cardiovascular issues. If they have some kind of neoplasm, they don't. It's a long time before they get care. The OBGYN arrangements are difficult. So these counties, there's lots of counties like that. And then what can Mercer do in concert with tertiary care facilities to help those people?
Well, first we can turn out a physician that is well trained and has strong clinical skills, has the ability to be an independent practitioner, to evaluate a patient and make good clinical decisions. We can send them out there without debt, but they need friends in the business. They need to have a network, and they need to have backup. In years past, I was the only doctor in my county.
Really?
But I knew, I could call many doctors who could guide me through situations. I had good emergency services. I had a small hospital nearby where patients could be stabilized. Those hospitals have gone away. So what we know will happen if we put a young person out there alone is that they will burn out, or it's intimidating to be by yourself at times.
Sure.
One thing, we hope to send them out in pairs. We hope we can get some buy-in from economic development councils to realize that one physician in a community brings in $2.5 million in economic development. We hope we can tie them through to centers like Navicent with technology. Telehealth is here to stay. It's very meaningful. It allows me as an internist in Wrightsville to connect to you as a neurosurgeon in Macon, and you to examine that patient and give me guidance. And if I can keep that patient at home, it's better for the patient, it's better for my community. But if they need you, I need you to help facilitate that transfer. So we can establish that network, and I think we can do that around the state, because certainly Memorial in Savannah is a safety net hospital that's needed. We can do it there, we can do it in Columbus, and we can do it in Middle Georgia.
One of the things that seems to be going on is economics. So we have a lot of issues with who's paying for what, and the expense of health care is so extraordinary. So if a person shows up at a tertiary care facility, there's going to be an enormous amount of bills that are occurring. It's an extraordinary. A week or two in an intensive care unit is you're going to receive a bill that's astronomical. And the payment mechanisms are often disturbed, if one can say it that way. And that seems to be playing a major role in what we'd like to accomplish. And we have the Democratic Party did what they could do. The Republican Party's out there. It's like I guess a volleyball game. The ball's going back and forth. Who is suggestions? What suggestions do you have, or do you have some, about how what's the way we could economically do things? I mean,
well, the most important thing we can do to reestablish a reasonable health care system that provides quality of care is reestablish a primary care workforce. It's gone.
Yes.
And quality of care goes up and cost of care goes down when you have a strong primary care workforce. Now, that's not to say we don't need specialists. We absolutely do. But everybody needs to have a primary care physician that knows them, takes care of them, feels responsible for them, and answers their phone that they have access to. We need to stop using hospital emergency rooms as on-call services. We need to be available. We need to have staffing situations. But now again, and I hate to bring up telehealth again, but with telehealth, if I'm out of town in one community, my friend in the next community can actually cover for me and save a transfer. So I think that establishing the primary care workforce is the most important thing. And then preventative medicine, we have increasing amounts of data that help us predict what happens with certain health conditions. We use that data to to address problems and issues like high blood pressure, diabetes. Population health data should drive the cost of care down if we use it appropriately.
You know, one of the things that impresses me is how poorly hypertension is controlled. I mean, in rural Georgia. I mean, do you have any thoughts about that? I mean, are there statistics on the subject? I mean, many times it requires a substantial amount of effort to do that. I mean, maybe I see people that come to me that have had hypertensive hemorrhages. I mean, it's really a common story.
Well, I think that education's a huge part of that. And, you know, my patients, I used to say, we all eat like our grandparents, and our grandparents plowed mules and walked to town.
Yes.
You know, but we still eat incorrectly.
Lots of salted pork chops.
But also, most people, if you can establish a relationship with a physician that cares about you and that you know is concerned about your well-being, you can increase medication compliance too. There's some very inexpensive medicines out there. The health department system, public health, is vital in that. They used to run a program called SHAP where they used old medicines, but they were good medicines and they were cheap medicines, and that kept people at home. But when you have to drive 30 miles to see a doctor and you're trying to raise a family or go to your job, it's impossible.
Yes.
And when your medicine that used to cost $10 now costs $100, you just give up. The pressures are too great.
Yes.
So there are a lot of issues, but they're not all about the patient. A lot of them the system. It's very hard to access care for people.
Well, you know, it's access is an interesting word, isn't it? So it's a lot of access is determined by money. And so one might say, well, you can just go see your doctor or whatever. The problem is your deductible is $1,000, or you can. And many people are put off by the deductibles. The other thing that happens is that the arrangements in some ways prevent care, if one could say that. You have access, yes, you could see a doctor, and the doctor could order this or order that. But many times the insurance won't allow that to be done or require this or require that. So there are tremendous barriers to appropriate care.
Insurance companies, and I know they have a job to do, and I know they serve, you know, people very well in many ways, but some of the access issues are related to insurance. Credentialing, you know, they have a small network, and so a county may have one doctor, but they're not allowed on the network of the insurer of the major employer in the community. Those are issues. But there are also things like federally qualified community health centers where you can go without insurance, get your medicine free or at great discount. Most physicians will see indigent care. You can't fill up your day with indigent care because you have to keep your doors open.
Yes.
So most physicians are benevolent and want to help people. You know, through the years, we took all comers, but we had mostly insured people, and I never, ever had a physician ask me an insurance status.
Really? Well,
when
good
I
for
called
you.
to review.
Well, I'm pleased to hear that, yes.
And because if you send them your insured patients, the people you refer to take your uninsured patients.
Well, we have a Hippocratic oath out there, and so one of the issues that physicians need, I mean, in my opinion, they need to have substantial responsibility for their calling, and it's not merely economic issues. They have a broader thing to accomplish. Well, what about mid-level providers? Is there a role for mid-level providers in the healthcare scheme, and is that a solution?
Absolutely, and you know, I have a master's in nursing. I've hired physician's assistants. I've hired nurse practitioners, and they have a vital role to play. I think that one thing that is always thrown about in Atlanta is we can send mid-levels out to rural Georgia.
Yes.
Practicing in rural Georgia can be very challenging, and you see amazing things.
Yes.
And you see very sick people. Mid-levels play a major role in establishing a network, but they need physician-led teams. Physicians need to take responsibility for those individuals and make sure that they work in a teamwork environment so they have adequate backup. I think that mid-levels, if you look at where most of the PAs are in this state, I think the last I heard, about 70% of them work for specialists.
Yes.
They did not work in primary care, and a similar number probably, though I don't know that the data is available for nurse practitioners. That said, I've gone to a nurse practitioner, I've been to PAs, they're great providers. They serve a real need in this state, but I think that we're better being a team together than we are independently.
Yes. Well, here's a question that's circulating in the world is prescription of opioids, opioid prescriptions, and I think particularly there have been problems out there. Do you have any comments about that? Are we trying to caution our young doctors about being nervous about this?
Well, we certainly educate them about it, and then the prescription monitoring program in Georgia is now available, and I think physicians are obligated to check that before they prescribe opioids. I think the problem has been laid at the foot of physicians, and I'm not sure we deserve all the blame.
Yes, yes.
Many of the overprescribing situations are driven by accreditors who call your patients when they leave the hospital, and the patient, Medicare had a quality question that they would ask patients, and the question was, were you in any pain? If you answered yes, the hospital was deemed a quality measure. Of course you're in pain. You had surgery. I mean, you had some pain. But it drove doctors to meet, you want to prescribe enough that the patient would say no.
Yes, yes.
I did a lot of geriatric care. The state would come into a nursing home.
Yes.
And if they ask a 95-year-old lady, did you have any pain? Well, she does have a little pain.
Sure,
Most of the time it's remedied by Tylenol.
Yes.
But, there's a great emphasis on checking for pain. I think regulatory issues, the State Board of Medicine has done a superb job, and I served on that board for a long time, but they did a great job of regulating pain clinics in the state.
Yes.
And that was a labor that they should take great pride in, because it really did decrease the number of inappropriate prescribing opportunities.
Yes.
But also, they track physicians, the DEA tracks physicians, and there are a small number of physicians that overprescribe. Those people are known, and I think deserve to be reined in a little bit.
Yes.
Most physicians don't overprescribe, and they are very responsible with their prescribing.
Yes. Well, one of the things that seemingly is going on now is the demand for physicians in the country. There's a major demand, and we have residency, sort of a disjunction between the people that are graduated from the medical schools and the number of residencies that are out there. And it seems to me that's a particular problem in Georgia. Is that not the case? Balanced Budget Act, 1997, there are not enough residencies.
There are not enough residencies.
You want to comment on that?
Well, Mercer's still very fortunate. I think that I'm right in saying that the match rate across the nation is about 80%. It used to be 100, near 100%. Mercer is still above, it's 98.9% of match. I think we do very well with that, but that's still always a challenge.
Yes.
New residencies are coming. I think that the legislature and the governor have been very instrumental in opening up new slots in the state. One strange thing, though, is a hospital that has established residencies and done a good job with those residencies, because of Medicare rules, is capped. And so they cannot add additional residency spots. Many people don't realize that Medicare, the Center for Medicare Services funds postgraduate training. And so a hospital that has a residency program and wants to add extra slots is not allowed to, because they're capped at a certain number. But a hospital that has never had residencies can open slots and be reimbursed for them.
Well, isn't that rather nuts? I mean, isn't this just an example of short-sightedness? And I mean, it's the way I look at it. If you have a residencies already there, you obviously have there's a lot of investment that's occurred. There's a lot of, I guess, people that know what to do, how to do it. The program is already established. It would be quite reasonable to expand the program there. What is the logic of not allowing an established program to expand?
I don't understand the logic of not allowing an established program to expand. I do understand the logic of starting new residencies in other places, but I think it's unfair to not allow established programs to expand. I'd like to see more residencies in medium-sized hospitals throughout the state, because you actually get a different experience, say, in a Dublin, Georgia, than you would in a Macon. And so the resident, in European hospitals and institutions, those residents typically spend time in rural and underserved areas as part of their residency training. We don't do that effectively in this country, and it's something that we need to do. So I would hope that the institutions that do residencies well should be allowed to expand, but I also think they should work with regional small hospitals to have residents rotate through those institutions and get some experience in those areas.
Well, one of the things I've observed is that just the supply and demand issue for residents, what maybe they need more ENT or more anesthesiologists, it seems to be not well thought out about how residency programs open or not open, and then the residency credentialing commissions that come through, they're rather restrictive about ultimately what can happen or not happen.
Absolutely.
At least in neurosurgery, it's very difficult to start a residency. Very, very tough.
And some of those standards seem perhaps to be based on practices that were accurate 10 or 15 years ago, and
yes.
they don't change with the changing times and changing technology either.
So just to get this point out to the public, the hospitals depend for their training program on government subsidies through Medicare. Is that correct? And if they don't receive such a subsidy, it's a financial burden to any healthcare institution.
Correct.
So that's a big thing. Well, how do you see things going at Mercer over the next several years? You want to make any predictions of how things are going to turn out?
I hope they're going to do well. But I think that we have so many things happening that we're excited about. We are working to really broaden our ability to address rural health issues, to come up with some of the solutions they need. We're very pleased with our partnership with Navicent and the new partnership with Coliseum. We have great relationships with hospitals in Savannah and Columbus. And we're also developing relationships and rotations across the state of Georgia to give our students a wide range of experiences. We hope to grow our class size a bit. We hope to really decrease student debt, and we hope to partner with communities looking for physicians with our Doctors for Rural Georgia Scholarship Program, so that these communities can welcome these young people into their towns.
And so the taxpayers of Georgia put a substantial amount of money in the Mercer Medical School, and they're getting what you would, we'll throw you one more softball, and you can hit it back. Are they getting good value for that? They're really getting good value.
We don't waste a dime over there.
Okay.
We want to give them every bit of value for their money, because we believe in our mission, and we believe that we can help change the state of Georgia.
Well, I think we've had a good interchange here. Let's see, we might have time for one more question. What could be our last question here? Well, let's see. Are you going to start a neurosurgery residency anytime soon?
I think we have great neurosurgeons here in town.
You might need a residency there. Well, it's been great talking to you, Dean.
Thank
you. Keep up the good work.
Keep
up the good work. Thank you.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.